So we're just going to get started talking about a little bit about ourselves and our program. I'm Dr. Bankowski. This is the most boring part of the talk, which is my personal education, but I got my kiddos up there. Ethan and Maggie are on top. He just won the state championship in lacrosse, so very excited about that. And then those are my twins, who that was their birthday a couple years ago. They were IVF twins after a couple of failed cycles. So my wife got older, things got more difficult, and lucky to have them. They're now 7. So I did most of my medical training at Johns Hopkins, and then I've been out in Oregon for about 13 years. And what has happened in Oregon is that because of the laws being very protective of the rights of intended parents, and because of our success rates being very high, we have started to do more and more international surrogacy and now treat about 400 international patients, and then more and more actually domestic patients for surrogacy. Compensated surrogacy has been illegal in most countries of the world for a long time, and in the US it's now safer and safer. You see states turning green, and that's been great. And now we have a situation where we're working with patients and agencies and donors from really all over the place. So this is our clinic. We're based in Portland, Oregon. This was brand new, built about 2 years ago. This is our embryo lab here, and then we see all the patients here. That's my office right there. We are now about doing about 2,000 cycles of IVF altogether a year, and a big part of that is surrogacy. A real key that some of us were talking about earlier is the quality of the embryo clean room, or the laboratory. That is what really sets rooms apart, and then your ability to do genomics as well. We approach everything with one goal, and that is to maximize the chances of a genetically healthy baby the first time that we're doing it. And everything that we do and how we do it is laid out for that. These are my partners. We altogether have 7 full-time physicians, 7 embryologists, 6 genetic counselors, about 25 people that are behind the scenes on a donor egg surrogacy process. That's how complicated it actually is to work with donors and surrogates and lawyers and agencies. And our group altogether is about 140 experts. So, and this is just a little bit about our company. Our goal is to grow families globally by developing the best team and processes and deliver really personalized care. This has a general format to it, but you might have different needs than you have, or different desires. You might be working with a different agency. So we really have to maintain the quality of what we do and the standards of what we do, and make sure that we individualize that to what your needs are as you go through the process. And these are our company's core values. And we are very proud to have worked with LGBTQ patients from over 40 countries in doing this, and be an active part of the GPAP program. Why come to Oregon? I jump to the bottom line. There's no taxes, so you can shop all you want in Oregon, but that's not really the most important part. It is a very clean and a very safe place to do this. And again, the reason why we do so much of it is because of the laws being very tolerant and very protective of the rights of intended parents, the combination of our success rates, and then the experienced team that we have. But what we find is that when the donors and the surrogates come to us, they really actually enjoy doing this in Portland. You come, as we've talked to you, you really come now to the clinic one time, and you should go to whatever clinic you think is best. Then where you choose your surrogate to be depends on the choices that you'll make. Your surrogate can come from anywhere. Some people are interested in a local solution where their donor, surrogate, clinic, agency, lawyer are all in one place. We have actually 12 surrogacy agencies in Oregon. And we work very commonly with 2 of those that are very experienced to do that. That's not the norm anymore. It used to be much more common, but now people are choosing the best. But what you should do is you should Skype with your agencies and your clinics to get more information about all of them as you go through the process. We have an active in-house donor egg program. We choose to show you a much smaller pool because everybody we want to show you is completely tested and completely screened and ready to go right away. okay? Because that is what's best for our patients. We show a number of detailed information on just the front page so that you can see that, but also there's 20 pages that you can see. You don't have to work with our donors, but our donors are tested up to here, and any outside agency donor we've ever seen from anywhere requires additional testing to get up to the same level of safety. I only care that you love your donor and that she's giving you the best chance of making a genetically healthy child based on, number one, her numbers, her performance, and her personal profile. This is our genomics team. This is really where we excel. This is the biggest team of reproductive genetic counselors anywhere that we know of in the world, and they do an amazing job of helping us to utilize the technology now that exists for carrier screening of donors and for genetic testing. There's two types of genetic testing. One is before the embryos are made, right? Do I carry a disease, a mutation for cystic fibrosis or Tay-Sachs or Gaucher's? We screen everybody for everything, basically, which is over 170 diseases. All the donors are automatically pre-screened with a panel called Counsel. After the embryos are made, when the sperm and the egg DNA come together, 3 billion base pairs of DNA merge, and that's very complicated. And that's when the PGTA, as they called it, or we would call it comprehensive chromosome screening, CCS, that's where we employ that after the embryos are made to make sure we're transferring chromosomally normal embryos. And that's what I just described. Pre-embryo creation, the two things we do are carrier screening and the family history, and after creation, the ability to do PGS or CCS, and then if you have a specific disease, PGD, you probably don't need that, but if you were to have that, we would test for that as well. This is some data that they didn't show today, but this is what's important here. I was talking to you earlier, 33,000 tested embryos showed that 39% from a donor are abnormal. This is why 99% of the patients that we treat choose to do CCS. With this type of technology, we're able to identify the embryos that would never make babies, and there will be negative cycles. If we avoid the transfer of those in our program, we clearly show a statistically significant increase in live birth rates. The benefits are it decreases the negative cycles, the pregnancy losses, the cost, the time to a genetically healthy baby. And if you have negatives or miscarriages, after a while, you're going to worry about the surrogate and want to rematch. This is a woman who's already had healthy live births. There's probably nothing wrong. It may be an embryo issue. If we do CCS, we avoid that, and you can identify the sex. Our survival rate after damage is 99.972. Okay, it's a very safe procedure. 2 to 3% don't survive the thaw, but the benefit to risk seems to be positive for most of our patients, and that's why they choose to do it. This is our live birth rate data. All programs are not the same. You can see this data in a couple of places. The most commonly done is SART. The national averages for donor egg surrogacy, if you look at it, is 54% for a single embryo being transferred. Over the last 4 years of data put together, we've done 187 transfers, and we've had a 64% live birth rate. If you were to transfer 2 embryos together, one from one person or from 2 different people, we've had an 85% live birth rate. But the rate of twins is about 2 out of 3, and that increases your risks, and you have to be very well aware of what might happen. Now, to be quite honest, the risks that people are quoting in the numbers are not in surrogate-specific studies, because nobody has ever done surrogate-specific studies. We are right now putting together a study of 1,000 surrogacy cycles to show what the outcomes are, and my impression is that they will be better than the general population because surrogates are handpicked, because they've had full-term live births without problems. But if you want to prioritize success rates, you're increasing risk, and that's something that we want you to understand very well. So why ORM? Number one, experience. We did over 10% of all IVF cycles for surrogacy in the most recent data. And we've had hundreds of babies born in recent years, and we've completed about 1,000 cycles to date. Part of the reason is because our success rates have been so high, not just in surrogacy, but in everything that we do, and you can see that in the SART day. And most of the reason is right in here, which is this entire team. I couldn't bring them all to Florida, though I'm sure a lot of them would like to come, but this is a team sport, and we really are so lucky to have experts in embryology, genetics, psychology, and then my partners as well to create the best experience for you. And that's that. Questions. That was a whirlwind tour just to give you intro. Questions that you guys have about anything that I talked about or anything you heard today.